Very good afternoon to all of you. Gives me great pleasure to be here. Thank the Andhra Pradesh Ophthalmic Society. I thank my friend Dr. Sujata for being here. It's heartening to see that there are at least 4 or 5 other than the speakers in the audience, because oculoplasty is catching up as it should. It's the bridge between of the eye and the body. So I bring you all greetings from my alma mater, Sarojini Devi Eye Hospital and Regional Eye Institute in Hyderabad. So my topic, I'm going to talk about thyroid eye disease. I know it's a much spoken topic, too many things to do, and I have another speaker who's going to speak on the very important side effect of thyroid orbitopathy, which they have to correct. So this picture is very interesting. That is the picture on the gate of St. John's, Cambridge, and it depicts a person. This is way back in 1516 and depicts a person with exophthalmos, which shows that thyroid orbitopathy was recognized even way back then. And even in 1040 to 1136, Zain al-Din Syed Ismail ibn Hussein, it's a very tough one to pronounce, in his treatise did mention about thyroid orbitopathy. So what are you seeing in all these pictures? What is common to all these pictures? It is the lid retraction, which is the commonest feature of thyroid orbitopathy. The dysthyroid neuropathy is the worst, but the commonest is the lid retraction, and therefore we need to see how we are going to treat it. I'm not going to talk about the Rundle's curve, about all the other features, the classifications and all. Going to concentrate on two things. One is the lid retraction, which is the commonest feature, and the second, which is not very often dealt with, the psychosocial impact of thyroid orbitopathy on the patient. So as we all know, upper lid retraction is the most common ocular feature of thyroid orbitopathy, and the mechanism for this is proposed that there is increased sympathetic stimulation or tone of the Muller's muscle, both in the upper and lower lid, because you have scleral show upper and lower. And as the disease progresses and becomes old, fibrosis sets in those muscles, which give a permanent lid retraction. The proptosis, which is present along with thyroid, also contributes, because the eyeball is pushed out, the eyelids are pushed back, which also causes lid retraction. Now there are various methods tried. As you all know, in the Rundle's curve, in the active phase, you can only use symptomatic therapy for the thyroid, no permanent surgical outcomes, unless of course thyroid optic neuropathy is threatening and there is no other way to treat it. So all the symptomatic or the temporary measures used were hyaluronic acid to weigh the lid down and bring it down so that there is no lid retraction, because lid retraction often causes a lot of undesirable side effects to the patient. Botulinum toxin also has been tried with variable success rates. Sometimes it is successful in some people and some people not. Cannot really predict in whom it is successful and whom it is not. Triamcinolone is the other old tried and tested therapy for injected into the levator muscle, and this is often useful. And my points are only going to be about triamcinolone, because we did a study and found a lot of wonderful results. So the definitive surgery, as we all know, has to be tried after the disease has died out, and various graded resections of the molars and LPS are available to us. Weight sometimes have been tried. So we recruited a total 26 eyes of 19 patients in our study, and the disease severity was graded based on CAS score, and who had a CAS score of more than 4 to 6, not the people who had very low CAS score, were subjected to triamcinolone injection subconjunctivally. They were reviewed at 2 weeks, 1 month and 3 months. This is the procedure. You can see that we are using a insulin needle and we are going between the molars and the LPS. Now what we noticed, to our pleasant surprise, was that not only the lid retraction but also the lag, the exposure keratopathy, the extraocular muscle restriction and the proptosis surprisingly reduced extremely well at 3 months time after giving the subconjunctival triamcinolone injection. The CAS activity, of course, when the proptosis subsides, when the lid retraction subsides, exposure keratopathy is bound to go down. So these are a few pictures of the patients we had. You can see the lid retraction and you can see her picture after we have given the triamcinolone. There are 3 pictures here, 3 patients. So this into LPS and molars we found was a very effective treatment in resolving upper eyelid retraction due to thyroid, and it worked best in people who were not having a TED of more than 12 months duration. Now the second aspect which I mentioned and I wanted to say is the psychosocial aspect. So this patient started our thinking and going into this. She was a school teacher. She had only lid retraction. CA score was quite low in her, and because of the lid retraction she was having problems, and that is what she told us, that she cannot go to school, cannot continue her job and other things. So therefore, searching history, we found that many of these people were thought to be psychologically affected. If you see what I have underlined in red, this is Parry, Caleb Parry has written a treatise about what patient he saw in 1786. After delivery, we know thyroid changes suddenly after after the onset of menarche, delivery, menopause, the thyroid hormones change, and what they saw was that the patient exhibited an appearance of agitation and distress, especially on any muscular exertion. So that tells us that there was a psychosocial element which was recognized even then. Robert Graves also mentioned that a lady became affected with symptoms which are supposed to be hysterical. So again, patients with thyroid related orbitopathy were thought to have some kind of a psychosocial illness. The constant watering, the dryness of the eye induces the patient to have lot of rubbing, feels a sense of isolation because they do not look normal and they themselves are very conscious. Vision is blurred, which affects many people's profession, which requires clear vision. So quality of life studies have shown that thyroid eye disease may have more significant lifestyle consequences than chronic lung disease or diabetes mellitus. And we did a study to analyze the correlation between the clinical grading of the systems used with the patient's perception of psychosocial limitations or isolation and other things. And we used a questionnaire where we used questions about visual limitations during driving, the profession, what they do, household chores, depending on the category of the patient. Psychosocial limitations, where the patient was not able to go and mingle with people in functions and other things. And then we also asked a question that whether educating them about their disease helped them to overcome their sadness about what they had. So when we plotted a scatter plot, we saw that though the CAS activity was not much, the psychosocial limitation was much more. Same with UGOGO and with Visa also. So we found that the psychosocial impact did not always correlate with the severe CAS scores. People with just lid retraction, people with a change in their appearance did perceive the severity of the disease in their mind, not graded by us as a CAS score. But counseling did help them, and therefore we feel that this requires to be addressed and included in the classification. I always like to end with these lines of Sir Duke Elder, which I feel hold good today. I am going to read out from Sir Duke Elder. Thyroid related orbitopathy is a very common condition which leads to disastrous consequences. The cause of which is unknown, we know a little bit today. The pathology obscure, and the therapy is somewhat ineffective, and is certainly no cause for congratulation. Thank you so much.
Thank you, ma'am. Nice presentation. So then we move on to next presenter. Ansua is not here, so we can call to Dr. Anila on dermoid excision.
The presentation. Excuse me. The presentation is not. No, it's not coming. Good afternoon, everyone. I'm Dr. Anila Sarvani, oculoplastic surgeon. I first thank the scientific committee of APOS and especially Dr. Sujata ma'am, who is the guide behind me taking the oculoplasty. With this, I first start my presentation coming to dermoid cyst. What are the tips and tricks to prevent recurrence? So this is the overview of my presentation. Dermoid cysts are the most common orbital tumors which we encounter in our routine clinical practice. So what are these dermoid cysts? They are the benign choriostomas which arise from sequestration of ectoderm along the lines of embryonic fusion of mesodermal processes. They can stem from any of the sutural lines in the orbit, but the most common is the frontozygomatic suture. With the desquamation in the epithelial lining, and these cysts tend to enlarge over a period of time. So coming to a brief anatomy, this is the most common part where we get the dermoid cyst, followed by the zygomatico-temporal suture, zygomatico-maxillary suture, and the medial dermoid cysts they can arise from any of the sutures like frontomaxillary and nasomaxillary sutures. Coming to the this is not working, excuse me. Laser pointer. Okay. Coming to the anatomy, here around the frontozygomatic suture, we should keep in mind about the frontal branch of the facial nerve, and also during the medial dissection we should keep in mind about the supraorbital nerve, because if there any traction or resection of these nerves during the dissection may lead to impairment in later days. Coming to clinical presentation, the most common presentation is a painless subcutaneous mass along the sutural lines. In this patient, we can see that this is the most common type of presentation where the posterior margin is palpable. In such cases, any radiological this thing is not needed, but sometimes just to be on a safer side, we can go ahead with a CT scan. This is the second patient where we can see ptosis, which is restricting the field of vision, and also the cosmetic impairment. The third is proptosis. The patients here presenting in dermoid cysts with proptosis are usually late, because only with apparent proptosis, when the lesion is almost space occupying inside the orbit, when there is no other space to present, then the patient presents with proptosis. Sometimes here in this patient, we had this patient when his vision is almost 6/60, because the tumor is impinging on the optic nerve. His color vision was also deficit at the time of presentation. So the most common used imaging is computerized tomography, where we can usually see a well-defined hypodense cyst with a hyperdense lining. So coming to surgical management, excision biopsy is the treatment of choice. But here the most important is where the incision has to be given. If the mass is anterior to the frontozygomatic suture, usually the upper lid crease incision would suffice, which usually gets camouflaged. If the mass is superior to the frontozygomatic suture, suprabrow or infrabrow approach, and intraorbital, what I usually do is, instead of eyelid crease incision, I usually do lateral, in case the mass is in the lateral orbit, in between the lateral rectus and the lateral rim, we usually do a lateral canthotomy with cantholysis. So here we did a upper lid crease incision in this patient. This second patient, this is a recurrent type of lesion where she has underwent surgery almost twice. Coming to other rare type of mass, this is a dumbbell or bilobed dermoids. These lesions, they transverse the bony sutures and expand into the adjacent chambers, and the meticulous dissection is of utmost importance to prevent recurrence. And here, this is a medial lesion in the nasoglobular region. Here in this patient, CT scan is a must, because we have to differentiate between an encephalocele and a dermoid cyst. So these are the post-operative pictures where we can see this is the lesion, and here we have given a incision where it is beautifully camouflaged into the eyebrows. Here we did a lateral canthotomy with cantholysis, and proptosis has come down. This is a almost 1 week post-operative patient, and even the incision is covered up. Coming to recurrent cysts, they form if any of the epidermal elements are not excised at the time of primary resection. But in some cases, complete excision is very difficult in case of giant or large dermoids, or the dermoids which are deep in the orbit or adjacent to the vital structures like optic nerve and superior orbital fissure. In such cases, if there is any rupture, piecemeal removal of the cyst wall must be done to prevent recurrence. So how to prevent? Appropriate incision is the most, the area of the incision should be in alignment with where the mass is located, and adequate area of the dissection. So the goal should be complete removal of the cyst wall and also intact excision if possible. So in case of rupture, thorough wash intraoperatively and careful removal of the contents. If in case of there is any intraoperative rupture, all the content should be removed meticulously, and a thorough betadine wash should be done. And it is always better to use microscope in case of rupture to ensure adequate removal of the cyst wall and its contents. With this, I conclude my seminar, and I thank Dr. Sujata ma'am, who is my teacher, for giving me this opportunity.
Very good presentation, Anila. One little point I wanted to mention is that you can have deeper dermoids which are in the orbit, which cause proptosis, and the more anterior ones present at a younger age because there are more evident. And if you do rupture, which happens often if because the wall is thin, you could use blue to stain the entire dermis, the entire dermoid, so that you're sure that you've removed the entire thing. And nowadays there is also another method of injecting sclerosant into the dermoid without doing a surgical excision, where there will be no scar left. Good presentation, well done.
Good, thank you.
Dr. Santosh, would you come up on the dais?
Dr. Ansuva, are you ready with the presentation? You'll take some. Okay.
You ready?
Please carry.
So at the outset, I'd like to thank APOS and AIOC for giving me this opportunity. And the topic for my presentation today is MRI, reading between the lines for ophthalmologists. So this will be an entirely case-based approach. I have no financial disclosures, and all photographs have been used with full patient consent. So let us just start off by talking about this particular case. Here we can see an axial cut of a CT scan where there is an enlarged lateral rectus, but we can't really see any pathology within the lateral rectus itself, and it doesn't really help us to arrive at the diagnosis per se. So instead, if we get MRIs done for these kind of soft tissue lesions, here we can see a well-defined cystic lesion within the lateral rectus with hyperintensities within the cyst itself. And it does suggest to us myocysticercosis of the right lateral rectus muscle. So of course everything has to be clinically correlated, but MRI is better in terms of soft tissue lesions, and of course it has the additional advantage of not having ionizing radiation. Similarly, this is another case where there is a CT scan was done for this patient. The superior rectus shows enlargement. We can't really see the pathology very well, but the MRI shows a very beautiful round cystic lesion in the area of the superior rectus with a hyperintense lesion within it, which probably indicates the scolex of the cysticercus larva. On the other hand, of course, there are certain cases where MRI may not be completely adequate. So here we have a patient who was a 45-year-old male presenting with a large mass in the superior and the superotemporal right orbit. It seems to be have progressively increased towards the cranial cavity. What else do we need to see in this patient? We also need to know the status of the bone in this patient before we go ahead with surgery or planned surgery. We need to know whether the outer table or the inner table of the frontal bone is intact, and CT gives us that nice delineation. And here we can see that it has eroded through the frontal bone. Of course, it hasn't entered the cranial cavity. We can see the dura is intact, but we should not take up this patient just in an ophthalmic setup without a neurosurgeon involved. Another similar case where we can see a hyper intense T1 weighted lesion in the left orbit near the greater wing of sphenoid. We cannot identify exactly where in the greater wing of the sphenoid it is, but here on a CT scan we can see that the sphenoid bone is eroded in that focal area, and this was a biopsy proven case of Langerhans cells histiocytosis. Now let's come to this patient who was a 60-year-old lady. She had complaints of right eye proptosis for the past 3 months. She had movement limitation and slight decrease in vision in the right eye. So these are all the various sequences and the MRI images of this patient, and it gives us a lot of different types of information. Of course, like we can see right at the outset that this is a large well-defined intracorneal lesion which is pushing the optic nerve laterally, and we can immediately jump to certain differential diagnosis like cavernous hemangioma of the orbit, schwannoma, SFT could also be one of the differentials, but let's look at what other information we can glean. So before going into the lesion itself, what are the respective sequences of these two MRIs? So we as ophthalmologists, we know that okay, vitreous is dark on T2 and vitreous is bright on T2 and dark in T1. We know that, but you know, we're not really used to looking at CSF. We're not used to looking at the brain. So it's something that we should also be aware of, that okay, we can't see the vitreous in here because there's no globe. So what are these respective sequences? So this, it's easy to remember. T1 weighting causes the nerve connections of white matter to appear white and congregations of neurons of gray matter to appear gray. So first picture is T1, second picture is T2. Another thing which is, you can see it's written TIR/M at the left corner of this orbital MRI picture. And what does it mean? It means turbo inversion recovery magnitude. It is also called turbo stir, and it is an effective method of fat suppression. So we know that the orbit is full of adipose tissue, which acts as an external contrast agent if it is fat suppressed. So this TIRM is nothing but another way of fat suppressing, and in head and neck cancers, TIRM has been found to give both high signal in tumor masses and also low degree of overestimation of tumor size by reactive inflammatory changes in the surrounding tissues. Moving on, so this is another patient who had a large cystic lesion in the left orbit, and these are the 2E2 fat saturated images, which shows heterogeneously bright signal changes of the wall and dark signal changes within the matrix of the lesion. Additionally, the radiologist had also reported that there was no significant diffusion restriction noted within the lesion, which gives us the additional information that it is not a hypercellular mass. Coming back to our case, so on the left we see, so it was biopsy proven schwannoma, cystic degeneration of schwannoma, and on the right we see a very similar looking lesion, intracorneal lesion. So how do we differentiate it? Both are well-defined lesions, iso-intense to muscle on T1. So something that can help us is contrast enhancement. So on the left side, the schwannoma shows patchy enhancement on contrast. On the right side, the cavernous hemangioma will have contrast enhancement which spreads from the center. Let's look at this patient who was a 45-year-old male. He presented to us with left eye proptosis, congestion, watering, and eyelid retraction. At initial glance, we can see that the extraocular muscles are enlarged. There is a little bit of tendon sparing that we can see. But we have to look beyond this as well. So we have to be closely looking at other structures also, such as the superior ophthalmic vein, which is dilated here. We can also see that there are structures other than the internal carotid artery which exhibit flow voids within the cavernous sinus. So this was actually a carotid cavernous fistula. I have multiple other examples, but we don't have time, so I'm just going to go to the end of my slides, and I'm just going to say that we should look at the whole MRI, not only the area of interest, and always correlate radiologically. That means talk to your radiologist as well whenever there's a doubt, because they can give you a lot of insight as to, you know, what we are looking at in cases or in difficult cases. Thank you.
That was a good insight into the MRI and the importance. And always, what I find is that quite often, few radiologists only are very attuned to orbital anatomy and orbital lesions. Quite a few of them in their training course don't have too much of orbits dealt with, and we need to, I mean, I make it a point and tell my residents to make a point not to look at the report. First, try to clinically correlate, try to understand what is the units there, what is the diffusion, what's everything, come to a conclusion, go back, look at the report, and then, like you said, correlate with the radiologist. So definitely MRI and CT both have their roles in orbit, and though MRI has come in, you cannot say that CT is totally ruled out in orbital cases, because you sometimes do need information about the bony orbit as well to plan your surgeries, to decide upon in thyroid, to decide upon whether it's a tight orbit, small orbit. Very interesting and educative talk. Thank you so much.
Thank you, ma'am.
And ultrasonography orbit also contributes, especially in case of orbital cysticercosis. So that definitely additional value with MRI.
Thank you very much.
Dr. Anuswa, will you come? Are you okay? Are you ready? Yeah. So now I invite, where is the talk? Yeah, to talk about management of eyelid tumors. She's from LVPI Visakhapatnam, Vijayawada, sorry. Neha.
Good afternoon, everyone. So in the next few minutes I will be taking you through 10 key points in management of eyelid tumors. So when you see these two patients in the clinic, are they same? Absolutely not. When you evert the eyelid, you see that for the patient on your right there is no posterior lamellar involvement, whereas for the patient on your left there is posterior lamellar involvement. So whenever you see a case of eyelid nodule, it is imperative that you do an eversion of the eyelid and see for the posterior lamella. Also, you need to look at all the danger signs of eyelid malignancy. Like if you see this particular patient has a yellowish irregular eyelid nodule, distorted eyelid contour, effacement of the meibomian gland orifices, loss of lashes, surface telangiectasia, surface ulceration, crusting, and on eversion a bilamellar involvement, which are all telltale signs of eyelid malignancy. So this was a case of sebaceous gland carcinoma. So there are other benign lesions as well, wherever the danger signs are not there, like squamous papilloma nevus or a molluscum contagiosum or epidermoid cyst. So for them we just do a in toto excision without any margin. Whereas when we come across the red flag sign and we flag it as a possible eyelid malignancy, we perform the excision with wide margin. We take 4 mm of normal eyelid on all sides. We also do a margin clearance and then only perform eyelid reconstruction. So I will come to that, what I mean by eyelid margin clearance. So when many a times, like in this particular patient, as you can see, the posterior lamellar involvement is more and we have to do a differential excision. That means the 4 mm margin we take from the involved area. So that is more in the posterior lamella compared to the anterior lamella for this particular patient. So intraoperative margin control, these were videos which are not playing, my apologies for that. So intraoperative margin control, we send margins for frozen section biopsy, like in the West, the Mohs micrographic surgery is also there. We don't have that at our disposal. So once the pathologist says that the margins are negative, then only we go ahead and do a reconstruction. Whenever, like for many facilities, frozen section won't be available, we can just wait for the fixed sections, the report to come, and then only we should go ahead and do the eyelid reconstruction. Moving on to pagetoid spread or the intraepithelial spread in sebaceous gland carcinoma, we know that it can happen in 16 to 80% of cases. So clinically, we can predict pagatoid spread by looking at these features: diffuse conjunctival congestion, diffuse thickening of eyelid, loss of meibomian gland architecture, loss of eyelashes, surface telangiectasia, any of these away from the main tumor nodule, we need to think about pagatoid spread. But this particular paper from our institute talks about, like you can see that with the presence of pagatoid spread, the globe salvage rate comes down drastically, and the metastasis and 5-year death rates are very high. And we found out that 10% of cases of pagatoid spread were missed if we just go by the clinical diagnosis. So based on this, we advocate that map biopsy should be performed in all cases of periocular SGC. So multimodal treatment for advanced tumor, like earlier for extensive sebaceous gland carcinomas, the only thing in our armamentarium was exenteration, but now we have a fairly established chemotherapy regimen with cisplatin and 5-fluorouracil. We give 6 cycles of this neoadjuvant chemotherapy. We bring down the size of the tumor, and then we perform conservative surgery for extensive SGCs. So it is also very important to look for regional lymph nodes, to palpate for the lymph node in the clinic in a case of eyelid tumor, and whenever it is there, go ahead and perform a FNSE, and if that is there is spread, we need to go ahead and do a radical neck dissection. So subclinical detection at the stage of micrometastasis of the lymph node is possible by sentinel lymph node biopsy, which is there in very few centers in India, and that would improve the overall survival by timely intervention. The post-operative protocol is of extreme importance in a case of eyelid tumor. So only a wide excision of the tumor doesn't suffice. We need to post-operatively, we need to look into the histopathology. Are there any histopathological risk factors, perineal invasion, or vascular emboli, which many groups advocate giving EBRT for them. There can be a fixed frozen mismatch, 2 to 10% reported in literature. That is, that frozen section was negative, but now on the report of the fixed section you get a positivity. So whenever there is margin positivity, we need to see whether it is a lamellar positivity or a full thickness positivity. If it is just lamellar, cryotherapy will help. For a full thickness positivity, we need to give EBRT. MAP biopsy positive, also we need to treat, like topical MMC, cryotherapy, exenteration are the options. And as I earlier said, regional lymph node metastasis needs to be treated. So we also need to know where not to excise, like while excision is the standard of care, there are few exceptions, like this is a clencher, a rapidly progressive vascular eyelid mass in a HIV and hepatitis B seropositive patient. It was excision biopsy was tried elsewhere. There was bleeding, so the patient was referred to us. Just on starting heart therapy, the mass came down. So spontaneous resolution is possible on improving systemic immune status in Kaposi's sarcoma. So again, this is a patient with multiple basal cell carcinoma, a typical case of Gall-in-Gall's cancer predisposition syndrome. So again, we need to understand that surgery or radiotherapy has a risk of induction of basal cell carcinoma in these patients. So there are multiple other associated developmental defects which are possible in this patient. So multi-system evaluation is important. To my last point, targeted therapy, like imiquimod, we use, this is a patient of xeroderma pigmentosum with multiple squamous cell carcinoma. So we used imiquimod for 2 months with the lesions coming down. So imiquimod is a good option and very easily available for multiple superficial squamous cell carcinoma or basal cell carcinoma. So for medical management, a drug which has been described in literature, but we don't have it available in India, is vismodegib, and it is used for unresectable or metastatic basal cell carcinoma, but it is extremely expensive and we need to give lifelong, where as soon as we stop the drug, there is recurrence. So to conclude, differentiate benign versus malignant, perform in toto excision for benign lesions and wide excision with margin for malignant lesion. Best to perform map biopsy for all periocular SGCs. Chemoreduction helps in performing conservative surgery for extensive SGCs. Screen for regional lymph node metastasis. protocol-based management following excision is very important in eyelid tumors. Know when not to excise. Targeted therapy, new hope for locally advanced and metastatic basal cell carcinoma. Thank you, everyone.
Thank you, Anasuva. Very nice presentation with all the pictures, very nice pictures and nicely depicted. Anybody having any discussion or doubts or anything? The audience? You want to say something?
I think it really needs to be reiterated again and again to the non-oculoplastic surgeons and lay people not to meddle with a suspicious looking lesion unless they are very sure that it is not malignancy, because those are the cases which become very bad, and not much, in spite of all the best therapies, sometimes the patient may have to lose the eye at best or life at worst. Sometimes they do spread. That's really necessary. What all the points you brought out are very important for non-oculoplastic people and residents to learn and take to heart, really. Thank you for a comprehensive presentation.
Now we can call Dr. Shalini Kumari. She's ready with the.
Thanks for this opportunity. The aim of this presentation is to highlight the importance of how active and independent assessment of CT MRI scans by an ophthalmologist can lead to an optimal diagnostic yield instead of solely relying upon reports of a radiologist. So we are always taught, read the scan plates, not the reports first. So why should an ophthalmologist learn to interpret CT scan when already we have the radiologist report? So we all know that orbital disease accounts for a very small part of the radiologist average CT scan load, and obviously they have less opportunity to gain expertise in this area, while we have a better anatomical and functional knowledge of orbital structures, and also we are well equipped with patient's clinical profile, so we have always an advantage over them. So the clinical information which is supplied by a referring ophthalmologist is essential for a radiologist to select an appropriate technique for imaging and also for deriving the most specific conclusion. If we fail to supply the patient's clinical data or the need for special scans, it will obviously lead to falsely negative CT scans. We don't need to understand the excessive technical and jargons of the CT MRI machines. We only need to read the reports. So the slice thickness, the usual one we ask for is 2 mm cuts. Also the modifications of CT procedures, like in to do Valsalva maneuver in suspected orbital venous varix, and also the simul CT brain scan, which is needed in cases of suspected neurocysticercosis with orbital involvement, and like in other cases bilateral heritable retinoblastomas. So mostly we are supplied with hard copies, but if needed, we can always ask for a link of scan online nowadays. So a gentle reminder for those who, for young ophthalmologists is for how to read a scan, note down the findings in detail, and then read the reports, compare both the reports, find out the discrepancies, and then reach out to certain diagnosis. We don't have in our campus the MRI scan, so mostly my talks are based upon the CT scan, our mistakes, and the lessons learned. So the case scenario 1, a female child 2.5-year-old, she came to us with sudden protrusion of left eye for last 3 days. These are the ocular examination findings. She had dystopia in left eye. The movements in certain gauges were obviously restricted. So the primary physician had already asked for the CT scan of the orbit without brain scan and without contrast. So this was the finding which we got on different sections. And the radiologist said that what he wrote was a well-defined isodense intraconal lesion involving the entire left medial rectus muscles, and his view was that it can be a lesion of inflammatory and infective etiology. though we didn't get a classical scolex picture what we see in myocystic sarcosis. So on a presumptive basis, we started with tablet albendazole and got steroid therapy, but also asked for the MRI scan from somewhere else. After 2 weeks, the patient turned with the MRI report, and the patient was not responding to the treatment. This time, on MRI scan, what we got to see that this same lesion is an ill-defined intraconal heterogeneous enhancing lesion, predominantly solid, with few cystic areas in the medial aspect of the left orbit. And the radiologist suspected diagnosis was lymphoma or rhabdomyosarcoma. I continued, our view was that it can be a case of lymphangioma. But since he raised the doubt of rhabdosarcoma, so obviously I thought that I should always take a second opinion so as not to meddle with patient's life. So in another center, the plain orbital USG was done, and they suggested us, since we have already started with albendazole therapy, so continue with it. After 3rd week, the child baby started responding with treatment or without treatment, still controversial. After 6 months, the patient was all right. After revisiting those MRI scan and CT scan, what we got to know that probably it was a case of lymphangioma, which is all well known that it can regress on its own. So lesson learned is, for us, learn to rely upon your diagnosis, read the scan plates yourself. Obviously, you can always take a second opinion. Case scenario 2. Another 34-year-old male patient with road traffic accident came to us on the 2nd day with ecchymosis in left eye and mild pseudo in ophthalmos. The rest of the examinations were like this. His ocular movements were full and free. Apart from mild in ophthalmos, no other complaints he had. This serial sequencing of sections of CT scan, you can see there was obviously the floor fracture which was comminuted, and the radiologist also said that there is a mild impingement of inferior rectus muscles. But on examination, we had ocular movement full and free. Just to confirm, we took the patient and did the force reduction test, which was free. So since the vision was 6/6, apart from mild in ophthalmos, there was no complaint. So we took the decision that we'll go ahead without doing any surgery. So observation was our approach. The patient is still under follow-up and he's doing well, and that's all. So we all know that in cases of fracture of the floor of the orbit, we should ask for, clearly write it down, that a reformated sagittal view along the axis of the inferior rectus muscle is a must. For evaluation, also for management and diagnosis. Our mistake was that we just wrote the axial scans and the coronal, not the reformated sagittal view, which we didn't get. So the lesson learned is that if we don't clearly communicate what 6 imaging planes of the scan is necessary to a radiologist, it can lead to difficulty in diagnosis and also the management. Case scenario 3. A 4-year-old child came to us with progressive swelling of the right upper eyelid superior nasally for last 6 months. On examination, we could see that it was a cystic lesion, but we couldn't see the posterior margin. Obviously, before taking it to OR, we asked for a CT scan. So on CT scan, the Hounsfield number for this cystic lesion is around 10. The radiologist said that it's a cystic lesion, probably of dermoid, probably a dermoid. To us, it looked like a plain cystic conjunctival cyst. We operated upon it. Histopathologically, it was confirmed that is a simple conjunctival inclusion cyst. So coming to literature review, we know that dermoid cyst will have fat contents. Fat has got -100 Hounsfield, so it will be hypodense. Maybe because of other components, it will be a little the picture like this. So obviously, it was not matching with our lesion. Okay, so the lesson learned is, being an ophthalmologist, we are better equipped with the knowledge of orbital and ocular lesions, so learn to question and discuss controversial inputs by radiologists. Case number 4, a 13-year-old female who came to us with RCS with ACS, but she used to evert her lower eyelid frequently in front of the mirror, and there was a soft, localized yellowish white soft mass in the left temporal fornix. And she was quite bothered about it, that remove this one. So we, to find out the extent orbital involvement is there or not, we sent it for CT scan. The radiologist said that is all normal. Problem was that we again went back, discussed with him, and then he confirmed that there is a hypodense lesion, very small lesion. The problem was that from our point that we advised axial and coronal scans, 2 mm as usual. We also mentioned lipoma, lipodermoid, left eye, but forgot to mention the zone that it was in anterior lateral part of the orbit. Probably it was a very small one. So while reporting, radiologist missed it. So post obviously we operated, and histopathologically it was confirmed. So lesson learned is, while advising a scan for orbital lesions, be thorough with the scan type, thickness, location, provisional diagnosis, and do discuss it with the radiologist. Take home messages, read your scan reports yourselves, and also take their positive inputs. Thank you.
Well brought out point. Just what we talked about in the previous talk on MRI, we said the same thing. And in Hyderabad, I have noticed that there are 2 or 3 pockets of radiologists who are very attuned to orbital pathology, where frequent referrals happen from the major institutes where oculoplasty is practiced. But the rest of them are still naive to the orbital lesions. Of course, COVID has made them very good about reading orbital involvement from sinuses and other things, but the other orbital lesions sometimes may miss their eye, and like you said, yes, we do need to correlate clinically, read it yourself first and then reconfirm it. Of course, the final diagnosis is always the pathologist.
Any other comments from the audience? Okay, now we call Dr. Shalin Shah. Is she away?
Dr. Shalin Shah.
And then Dr. Rachna Agarwal. Santosh, you want to present this topic of intraocular seeds in the...
You present the orbit first.
Oh, okay. Let me introduce. Dr. Santosh needs no introduction. Everyone sitting here, we all know him. But let me tell few points about Dr. Santosh. From the beginning, I have been seeing him as one of the very sincere, hard-working, highly academic person. Fortunately, I was his classmate at All India Institute of Medical Sciences, and he was topper of our batch. Then he did senior residency from RP Center. Then he joined L.V. Prasad Institute of Eye Institute as fellow in Oculoplasty, and then he was sent to US for ocular oncology fellowship. He was the first fellow in ocular oncology in India, and he is very efficient and very academic oriented person, and his presentations are very nice, and he is the best teacher in this section of orbit, oculoplasty and oncology. And his 3D presentations were wonderful. Nobody ever can surpass him in this regard. And he was the editor to IJO, and he has taken IJO from which level to which level we all seen, international level, indexed IJO. And then now he is our honorary secretary to the largest eye community in the world, and I'm very proud of him. This oration, we call it our lecture, special lectures, we started last year in my name as Dr. Sujata's oculoplasty, orbit oculoplasty lectures. So we first one we invited Dr. A.K. Grover last year to Eluru APOS conference, and second I'm giving the honor to my best friend Dr. Santosh, and let us listen what all he is going to share his experiences in this orbit and oculoplasty. Thank you, Santosh, for accepting our invitation. Please carry on.
Just want to say, I think I have a special name for him. He's the master blaster of oculoplasty and orbits. I always call him that, like Sachin Tendulkar, because he really hits the nail on the head. and allows you to see it also.
Thank you so much. Thank you, Sujata. Thank you, Modini, for the kind invitation and the honor. I'll be speaking as asked on oncological principles in orbital surgery. Orbit is a box that's full of evil. You don't know what it is unless you have removed it, and pathologist obviously has the final word. So you have to combine your oculoplasty surgical skills with oncological principles. Otherwise, there might be situations where you might end up compromising life. Primary goal in any malignancy would be life salvage, and if that is possible, eye salvage, and tertiary goal would be optimal vision and cosmosis. So whenever you have a patient with an orbital tumor sitting in front of you, you have to ask these questions and answer these yourself. What is it likely to be? Is it a benign tumor or a malignant tumor? Where is it located? Intraconal, extraconal? Does it have extra orbital extensions such as to paranasal sinus or intracranial extension? What are its relationships? Is it related to extraocular muscles and the optic nerve? Is it operable at all or not? And if so, what approach would I take? Would I take transconjunctival approach, or would I rather do transcutaneous approach? Would I cut the bone? Would I not? What do I expect? Do I want to completely remove it, or would I just want to get away with an incisional biopsy? When you have to ask these questions and reliably answer before you counsel the patient and schedule a patient for surgery, you have to go through the logical step necessarily of clinical history, regional examination, relevant systemic examination as is appropriate with your differential diagnosis. Imaging, it could be an ultrasound B scan, MRI or CT scan, or even a PET CT scan, special investigations, surgery, and of course histopathology, most important, because based on that would you devise adjuvant therapy. So when you go through this approach, you have three conclusions. What do I do? Do I say no to surgery? That's a very clear answer. Of course, you won't do surgery in certain situations. I'll show you which. In certain situations, you'll definitely do surgery. And there are some gray areas where, depending on your competence and the facilities that are available, you may or may not do surgery. So with this approach, this is a patient child with bilateral proptosis with temporal fossa fullness, where you expect there to be a triradiate lesion involving the temporal fossa, orbit, and intracranial extension, bilateral without any periocular hemorrhage. Your primary differential diagnosis would only be metastatic Wilms disease, and you won't even do a biopsy here. Whereas exactly similar situation, triradiate lesion with raccoon eye sign or periocular hemorrhage bilateral, you would definitely consider metastatic neuroblastoma. Again, no surgery here. A child with unilateral proptosis, subconjunctival hemorrhage, rot spots in the fundus, you have no other differential diagnosis except granulocytic sarcoma, and the child only needs a peripheral blood smear to confirm the diagnosis that it is AML, and you send away the child to a pediatric hemato-oncologist. No biopsy here, not even a scan yet. This is a patient with prior history of multiple myeloma, now comes with an orbital mass after 10 years. You know the history that it is a case of multiple myeloma. So all you want to now confirm is the diagnosis that it is plasmacytoma, and FNAC would just suffice. You really don't have to open up the orbit. That being so, there are some non-surgical approaches to orbit as well. Like this patient, he doesn't even seem to have proptosis. Does he seem to have proptosis at all? I don't see it, right? Maybe 0.5 millimeter difference in exophthalmometry. But he has been failed in his recent medical exam. He was a pilot because of this posterior orbital mass, which we know already on MRI that it is most likely to be a cavernous hemangioma. But it is peeping into the superior orbital fissure, pressing on his optic nerve, causing his visual field defect, because of which he was failed in his recent medical exam. So would you want to approach this by surgery? Definitely it is possible. Cavernous hemangioma is a surgeon's delight, but being in this location, there is always a possibility that you might damage structures that pass through the superior orbital fissure. Even if you don't want to intentionally damage, when the tumor comes out, it may pull on some of the nerves. There could be a secondary hemorrhage, there could be further pressure on the optic nerve, or even optic nerve sheath hemorrhage, which may result in compromised vision and also functional deficit, which he currently doesn't have. So in these situations, you choose not to do surgery, but he wants his visual field back, so you plan stereotactic radiation just to this benign tumor, and you can show that the tumor has reduced by about 70% of its initial volume. Residual lesion is only about 30 to 40%, thus relieving pressure over the optic nerve and complete reversal of his visual field defect. So with a good radiation oncology facility, you can plan to radiate just the tumor itself, avoiding bystander effect to the optic nerve and the retina. This is from the literature where a much smaller dose of 2000 centigrade using gamma knife was delivered for a much smaller lesion with much severe visual field defect, and there is complete reversal of visual field defect. So radiation could be considered in a patient who has a pear-shaped lesion where there is no clearance at the orbital apex, where surgical maneuvers can be dangerous. Injections, of course, has been overemphasized recently. There are drugs that are available for lymphangioma. There are many drugs including tetracycline, but picibanil and bleomycin are currently preferred. Picibanil is a very gentle drug for the optic nerve, that is why it is preferred. Bleomycin is good enough. Now this is a young lady who comes with unilateral proptosis. Her only complaint is that she doesn't look good and she has periocular hemorrhages and subconjunctival hemorrhages which happen on a recurrent basis and take time to resolve. And during the phase of resolution, she always has that hesitancy in facing public because she has subconjunctival hemorrhage. Now she has a tumor which is all around her optic nerve, lateral rectus, lacrimal gland, SRL complex and the medial rectus. So you cannot easily debulk this even by the supratemporal approach. In such a situation, we would use picibanil and not bleomycin because we are injecting right next to the optic nerve in the intraconal space, and you can see nice tumor clearance over 3 injections, and she has actually got the cosmesis that she always wanted. Tumor may not always completely go away, but sclerosis enough not to remain symptomatic. In a patient with who has macrocystic lymphangioma where there is chocolate cyst, you would simply aspirate the content of the cyst and inject bleomycin, and this is one such patient who is relieved of his chocolate cyst. Another child who has acutely bled in a pre-existing lymphangioma with corneal exposure, etc., following evacuation of the contents, that was clotted blood, and injection bleomycin. Anteriorly located lymphangioma, again injected with bleomycin. So injections are definitely the way to go for venolymphatic malformations. Now this is a patient who has a kind of a subacute or a chronic proptosis, and based on the location of the lesion and triradiate, of course, you suspect that the child may have eosinophilic granuloma, but there is no proof as yet. For eosinophilic granuloma, curettage is the treatment of choice, but since it has already disturbed the dura and there is no roof of the orbit, curating in this area would mean that there could be CSF leak, and that would also cause for orbital reconstruction, which would make the surgery more morbid. So in such a situation, we would go with the safe approach of doing a biopsy from the center of the lesion without going much towards the dura and wait for the pathologist to confirm the diagnosis. Most of the ophthalmic oncopathologists are confident enough to give this diagnosis on a imprint or even squash cytology or frozen section, and if they confirm the diagnosis on the table in about 10-15 minutes while the child waits under anesthesia, you would go ahead and inject the lesion with triamcinolone. Just that, and then you can see 3 months later the bone is partially remodeled, 6 months later bone is completely remodeled without needing a major surgical intervention. So this is possible if you have a situation where your pathologist is able to support your rapid diagnosis while the patient waits under anesthesia. This is one more recent patient where there was a breach in the roof which is now settled down, and the lesion is on its way to regression following triamcinolone alone. Now about incisional biopsy. There are clear indications for incisional biopsy. If a lesion is poorly circumscribed, when you suspect a malignant lesion, when you cannot remove it completely without causing functional issues, and you have a differential diagnosis, not a definitive diagnosis based on your clinico-radiological evaluation and systemic workup, you would want to do an incisional biopsy because you don't know what it is and how else it can be treated. In such a situation, doing a biopsy is okay. But if you look at the literature, you find that about 8 to 20% of orbital biopsies either result in non-specific or misleading wrong diagnosis, leading to inappropriate treatment. If you have a wrong diagnosis, you go on it and treat the patient, which may not result in resolution. I'll tell you upfront that it's a child with rhabdomyosarcoma of the orbit. I'll also show how I do biopsy. When I do biopsy in this patient, I know the epicenter of the lesion is this on radiology. So I would do a superficial biopsy, I would do a mid-zonal biopsy, I would do a deep biopsy and send all this to the pathologist. Or you can do a deep biopsy where all the part of the lesions are included. But you should definitely go beyond the epicenter of the lesion, because if this is the lesion, the epicenter would consist in a round cell tumor of necrotic element, the mid-zone would have the real tumor, and the periphery would be the tissue reaction to the necrosis or inflammation that a round cell tumor would induce. So if you do biopsy only from the superficial lesion, this is what it would show: inflammation and fibrosis. Now based on that, if you treat the patient on oral steroids, it will partially resolve, and you get into the aspect of being confident that okay, it's going to resolve, but the child is going to obviously get metastasis. So In such a situation, what gives you the diagnosis would be either a mid-zonal or a deep biopsy, which confirm the diagnosis of rhabdomyosarcoma here, so we could further treat the child. This was a bilateral orbital mass with telecanthus, which is acquired. Now, in this patient, we did a biopsy, and superficial biopsy showed inflammation and fibrosis. Deep biopsy simply showed granulomatous inflammation, which would still warrant steroids after systemic evaluation, but only when we asked for special stains could we diagnose that it was indeed a fungal granuloma, where steroids would absolutely be contraindicated. So unless you ask for special stains in a given clinical situation, the pathologist may not do it. Or if you don't ask for microbiology evaluation or preserve some fresh tissue for PCR, you may not get the diagnosis. So you don't have a second chance here. You should anticipate the diagnosis and get appropriate investigations. In excisional biopsy, the indication is that it should be a well localized and a circumscribed lesion which is non-infiltrative and not associated with crucial structures. Irrespective of whether it is benign or malignant, you would completely excise. There is no role for an incisional biopsy in a well circumscribed tumor, because if you want to leave a part of it behind, how else can you manage it? It's very difficult. So when such a situation arises, there are many surgical approaches. Anterior orbitotomy, of course, there are many named and unnamed incisions. It can be used for dermoids, lymphangioma. Now it's treated, of course, with injections, but earlier we would even do a lid split incision, which is called Byron-Smith incision, to access a suprarenasal lesion. But currently all that is gone, and we do a safe lateral orbitotomy approach where we go by the lid crease mostly, and if at all it's a lacrimal gland tumor, we may go with a very lazy stellarite incision. These are the two popular incisions currently used. But what is also important to know is that there is minimal surgical approaches now, which is by the conjunctival approach. This is to show that about 70% of the orbit is accessible by conjunctival approach. Medial for sure, intraconal or extraconal, inferior definitely, lateral up to the lacrimal gland. Superiorly you cannot do conjunctival approach because the superior, of course the LPS would come in the way and you would cause ptosis. So there are many incisions in the conjunctival approach. This is a child with a teratoma, where it was a benign teratoma, where the lesion was both on the medial as well as the lateral side of the optic nerve. That's a fully grown molar tooth within it, confirming radiologically the diagnosis. That's a swinging eyelid incision that we use. That's a cystic lateral component. That's the optic nerve. We could visualize it under the microscope. And the medial component was much tough and solid, and that was the groove through which the optic nerve was passing. That's the medial, and that's the cystic lateral component, all of which could be visualized and removed by this approach. Now all the child now has residual is an esotropia which can be fixed. Optic disc edema is completely gone, so the child has good visual prognosis. Now this is a lady with an intraconal cavernous hemangioma. She is a professional. The lesion was pressing on the optic nerve and she did not want a bone cut, and she wanted to go back to work very soon. In this situation, again, you can use a transconjunctival orbitotomy approach, where you would not cut the bone at all and then do a minimal surgery. This is a lateral canthotomy incision, which is just about 5 mm. Inferior cantholysis to get egress to the inferior fornix. Quickly forward the video. Conjunctival incision has been made. The bone is ledged, and you expose the periosteum very close to the inferior orbital margin. Once the periosteum is exposed, you make an incision in the periosteum, again very close to the inferior orbital margin, not to damage the infraorbital nerve. Then you dissect the periorbita until you either visualize the inferior orbital fissure, the apex of it, or the infraorbital nerve, both of which you don't want to damage. And once that is done, you have to make an incision in the periorbita in the quadrant where the tumor is located, after cauterizing the blood vessels which are bleeding through the bone. That's the incision in the periorbita we are making in the quadrant where the tumor is located. Rest of the dissection is carried out by blunt dissectors to visualize about 2/3 of the tumor. When the lesion becomes easily ballotable, then you apply a cryoprobe for a good anteroposterior traction and gently ease the tumor out without pressing on the optic nerve at any point in time, and always looking at the pupil. And as the tumor comes out, there is no hurry at all. You have to look at the posterior aspect of the tumor for a possible feeder vessel, and that needs to be cauterized. Otherwise, that blood vessel will retract into the orbit, bleeding, maybe causing secondary hemorrhage. So that's the feeder blood vessel that was cauterized. And now all we need to close is just the lateral canthotomy wound that we have made. It's a 5 mm cut, the minimal access to the orbit, and most of the tumors in the lateral, inferior and medial orbit can be accessed exactly similarly, and conjunctival closure is also easy, and morbidity is very minimal. The same patient looks like this after about 3 weeks without any morbidity of lateral orbitotomy. This was a neurolemoma approach by the similar approach. I'll skip this video, lateral orbitotomy without a bone cut. But what next after surgery? Of course, the pathologist will tell you the diagnosis, and based on that, you might want further treatment. This was a mantle cell lymphoma which needed rituximab treatment, and of course, many patients we have been able to avoid orbital exentration. There's a child with orbital retinoblastoma by just doing enucleation after multimodal treatment, giving them good cosmesis. One more child with orbital retinoblastoma treated similarly. Approach is used for abdominal sarcoma as well, where the tumor is around the inferior rectus muscle. For example, this child has a large inferior orbital mass and it is located around the inferior rectus muscle. If I were to completely remove it, I would sacrifice the inferior rectus, thus causing refractory strabismus, which is very difficult to repair. So what we do in this situation is leave a bit of the tumor around the inferior rectus and remove the rest. So that groove has been left along the course of the inferior rectus muscle, and rest of the tumor has been removed. Rest of the treatment, of course, is by multimodal treatment, which anyway the child needs in RMS, chemotherapy and radiation, and you can maintain function and vision. This is a child destined for exentration. There is no reason why we should not do it, but it is not safe at this point in time when the patient has presented. So we chemoreduce this patient, do a safe exentration, then we can use the skin flaps to provide an exentration prosthesis. In adenoid cystic carcinoma, the protocol is established that we have to begin with neoadjuvant chemotherapy, shrink the tumor down, and then do a complete en bloc excision and chemotherapy and radiation. So basically, patients who have bone involvement now don't need an orbitectomy. They can be conserved, bone remodeled. So you can see the same patient after complete remodeling of the bone. This is a child with adenoid cystic carcinoma with bone involvement, completely remodeled following multimodal treatment. They don't need morbid orbital exentration. So in conclusion, I would say that's sebaceous gland carcinoma, which Anusua already showed. In conclusion, I would say that exentration can be avoided in many of these patients, and logical approach to orbit, starting from a good clinical history, radiological evaluation, clinico-radiological correlation, then deciding on whether you want to do an incisional biopsy and excisional biopsy, taking safe approaches to excisional biopsy, relying on the pathology for adjuvant treatment helps optimize the outcome. Thank you so much. I think I can skip that because the next step.
Very beautiful lecture as usual, and I'm sure all of us are going back learning much more than we came with. It's always I find every conference, every session a learning tool for myself. I request Dr. Santosh Honavat to come forward to, I should give it, you give it, no, your name, no? To receive the Oration Award. Oration is in the name of Dr. Y. Sujata.